Thank you so much. I appreciate you being here and those tuning in later to watch as well. Thank you to Gap and thank you to Madrigal for making this possible. So today I'm going to talk about a case and we'll discuss MASLD basics. So again, I'm Gabriella McCarty. I'm a nurse practitioner at North Shore Gastroenterology. This is a large private practice in the Cleveland area, and I have been there for the past 26 years. I do general GI, IBD, and hepatology, and I do come across a lot of fatty liver patients. Now, I'm saying come across because a lot of my patients that actually I see for fatty liver originally saw me for something else, GERD or even colonoscopy screenings. So I would say 75% of my fatty liver patients were coming in to see me for something else. And perhaps I saw they had metabolic syndrome, or I was digging through old imaging. Sometimes 15 to 20 years ago, patients had a CT scan or an ultrasound, and in the report, perhaps not even listed in the impression, but actually in the body of the report, there's a quick blip mention of fatty liver. So when I ask patients about that, half of them tell me they had no idea they had fatty liver. And then the other half of them tell me that, yes, my primary care told me I had fatty liver so many years ago, and they said not to worry about it, just to lose weight. So the bottom line is that this is much more common than you may think. So this is the QR code to register for the meeting. So you can go ahead and scan that. And then this is the QR code for the Madrigal Disease State Education site. So this is a community network, and you can view the disease state education and Madrigal Resdifra promotional program as well. All right, so let's get started. So you may have seen that we talk about fatty liver a different way now. This was finalized in June of 2023. There was a multinational consensus process that took place. And in conversations, I still often say fatty liver because it makes the most sense to people. But steatotic liver disease, which is SLD, is the umbrella term that was chosen to classify individuals with hepatic steatosis or fatty liver due to various etiologies. And those are listed here on the screen. On the left-hand side, you'll see metabolic dysfunction-associated steatotic liver disease or MASLD. And then underneath that is metabolic dysfunction-associated steatohepatitis or MASH. So this includes patients that have hepatic steatosis, plus they have at least one of 5 cardiometabolic risk factors. And then next, you'll see MASLD and increased alcohol intake. So this is MET-ALD. And this is further broken down by weekly alcohol intake or average daily alcohol intake, whether it would be more MASLD or ALD predominant. And to the right of that, you'll see alcohol-associated liver disease. So this is where alcohol is the predominant cause of steatosis. And then next, you'll see specific etiology, SLD. So this could be drug-induced, could be monogenic diseases. Now, monogenic diseases can include Wilson's disease, inborn errors of metabolism, environmental toxins. Some other causes that are not so common, there's LALD, which is lysosomal acid lipase deficiency. There's also hypobeta lipoproteinemia. That's a mouthful. And then under miscellaneous, that would be like HIV, hepatitis, celiac disease, malnutrition. Now, those patients that do not have any metabolic parameters and we cannot find a cause, that would be termed cryptogenic SLD, as you can see way on the right. Okay, sorry, I had trouble advancing there and then I advanced too much. All right, so if we look at the decision tree for classifying the type of SLD, MASLD is defined by having steatotic liver disease on imaging or by biopsy. And many times this is an incidental finding on an ultrasound looking for cholelithiasis. And then you ask yourself the question, does the patient exhibit any of the metabolic criteria? So this criteria is listed on the right-hand side, adults and pediatrics. So I do not see peds personally, I see adults, so I will focus on that today. But sadly, this condition is becoming more and more prevalent in the pediatric population, so much so that they have their own parameters. And I will discuss these parameters on an upcoming slide. But if a patient meets one of these 5 parameters, you have to then ask yourself, are there any other causes of steatosis? If not, you can safely diagnose them with metabolic dysfunction-associated steatosis or steatotic liver disease or MASLD. Now, if there are other causes like alcohol, so that would be a MASLD and perhaps ALD overlap or combination etiology overlap. Now, if the patient does not meet any of these criteria, then you ask yourself, are there any other causes of steatosis? So this is where you're looking for those other miscellaneous and monogenic diseases that I just mentioned. And if there's no metabolic criteria and no other cause can be found, they have cryptogenic disease. Now, many of our patients do meet this cardiometabolic criteria. So how will this change affect my practice? So we are talking about it a little bit differently. And as I mentioned, I still say fatty liver in the office. You know, patients understand that. But MASLD replaces NAFLD, MASH replaces NASH. But when it all comes down to it, there's a 99% overlap between the MASLD defined population and the historically defined NAFLD population. All of the recommendations and AASLD practice guidelines mesh with the 2 of those conditions, and the natural history and biomarker validation studies among patients with NAFLD and NASH are applicable to MASLD and MASH. So if anything, we're talking about this condition more, we're thinking about it more, and we're looking for it more daily in our practice. Education is so important. So I will mention that here, and I will mention that again and again, that educating your patients about this condition is very important. I mean, most patients still think that, you know, my liver's fine if I don't drink alcohol. So just telling patients that even without any alcohol use, fatty liver can eventually lead to cirrhosis. Educating your primary care providers on the importance of finding these patients and addressing these issues early before we have any progressive liver disease. So here we'll dive deep into that metabolic criteria. So MASLD is hepatic steatosis plus 1 of 5 of these cardiometabolic risk factors. So a patient would have to have number 1, a BMI above or 25 or greater, or 23 for Asian patients, or a waist circumference of greater than 94 centimeters in men and greater than 80 in women. Number 2 would be a fasting glucose of 100 or more, or a hemoglobin A1C of 5.7 or greater, or they have type 2 diabetes. Number 3 would be a blood pressure of 130/80 or greater, or they are on antihypertensive therapy. Number 4 would be triglycerides of 150 or greater, or they are on lipid lowering agents. And then number 5, last but not least, an HDL of 40 or less in males or 50 or less in females, or they are on lipid lowering agents. So this does exclude patients with alcohol consumption greater than 25 or 30 grams per day in men and women. But just looking at that criteria and thinking about this, many of the patients, at least in the Cleveland area, meet these metabolic risk factors. So now let's talk about primary care management, and if, SLD should be suspected. It should be suspected in any patients that meet that criteria that I just discussed. And really, any patient, we should think about it. Anybody with diabetes really should get a FibroScan in my thoughts. But in primary care, Fib4 is very easy to calculate as a primary risk assessment. So this basically uses the patient's age, AST, ALT, and platelet counts. If you do have Epic, you could just put .Fib4 and it will calculate it for you. Otherwise, it's very easy to just pull it up on your phone or on your computer to do that calculation. So non-invasive tests are reliable. We don't always jump to liver biopsy with these patients, but using these NITs or non-invasive tests are actually recommended by AASLD and most guidelines to risk stratify these patients. So between the lower risk MASLD patients to the at-risk MASH patients. So if you're starting at the box on the left, in your general primary care population, the goal is to exclude advanced fibrosis in low prevalence populations. If you do get a Fib4 score of less than 1.3, you would reassess with that score every 1 to 2 years in type 2 diabetics or pre-diabetics, or anybody with 2 or more metabolic risk factors, or every 2 to 3 years if there's no diabetes and less than 2 metabolic risk factors. If that Fib4 is 1.3 or more, then we need to do some further non-invasive tests to further risk stratify these patients. So as you can see here, 2 listed are VCTE, which is vibration controlled transient elastography. That is your FibroScan. And then ELF testing is a lab test. It stands for enhanced liver fibrosis. So FibroScan, it uses an ultrasound technique and it measures liver stiffness. So it gives us a couple scores, how much fat you have in the liver, and if you have any fibrosis or scarring in the liver. Those that would be deemed low risk have a kPa or kilopascal score of less than 8. Now, ELF testing, like I said, that's a blood test. And this is a good predictor of fibrosis progression. It actually measures biomarkers involved in collagen homeostasis or fibrosis, and less than 7.7. What we need to worry about, though, is these patients that are intermediate or high risk, and that would be a FibroScan of 8.1 to 12 or above, or an ELF score of not greater than 9.8. Now, if these patients are low risk, you would go up to reassess them as we would if that Fib4 was less than 1.3. If they're intermediate or high risk, this is when you do need to refer to hepatology or GI to identify and manage these patients with at-risk MASH or cirrhosis, or initially if the FIB4 is greater than 2.67 or they have persistently elevated liver enzymes, they should be seen in specialty care. Now we'll move on to specialty management. Once those patients are deemed intermediate or high risk, we have a decision to make. And sometimes we do still do liver biopsy if there are indeterminate non-invasive tests, diagnostic uncertainty, persistent enzyme elevation. And we see this. Sometimes the FibroScan is overread, especially if patients have hepatitis or cholestasis or congestion in the liver or a mass. On that note, always order an ultrasound, a regular ultrasound to rule out any early liver masses. Sometimes we'll see high IQR readings, maybe the probe hit over a vessel, or things are just not meshing with the patient's labs or their imaging. The CT scan might say the patient has cirrhosis, but then the FibroScan is F0 or vice versa. So if we are uncertain, we would still get a liver biopsy, especially with persistent elevation of LFTs. Sometimes I do order MR elastography, which is helpful with morbidly obese patients. And when you can't get a really good FibroScan reading, but this is expensive, it's harder to obtain, it's long, it takes a long time for patients to get in for this test. And at least in our area, patients have to drive downtown to do it, and nobody likes to do that. But that is another availability. And then, so liver biopsy would be staged. So if it's, 0 to 1, 2 to 3, and stage 4 is cirrhosis. If it's 0 to 1, you would reassess in 2 to 3 years. And I would reassess by getting a FibroScan, checking that FIB4 score. If their stage is 2 to 3, you reassess annually. I will get a FibroScan yearly. I will check yearly labs. And this is where you have that discussion with the patient that there is pharmacotherapy that's available now. Stage 4, so this is cirrhosis. So you would manage per cirrhosis-based management. So we do, HCC protocol, which stands for hepatocellular carcinoma. We check an ultrasound of the liver every 6 months and blood work, including a CBC, CMP, PT-INR, and alpha fetoprotein. And I see these patients in the office every 6 months. You would also suspect cirrhosis, or if you suspect cirrhosis clinically, or the alpha is greater than 11.3, they fall into that HCC protocol. I actually put patients with fibrosis score of 3 into that protocol. I may not necessarily see them every 6 months, but I will get the ultrasound and blood work. So as you can see, this is a global issue, and it is a growing crisis worldwide. The prevalence is increasing, and Dr. Yanusi and group actually performed these meta-analysis. You can see Latin America has the highest prevalence at 44.4%. So think about that when you're seeing your Latino patients. Western Europe is lowest at 25.1%. But the point is, it is everywhere. And due to this increasing prevalence, we need to really urgently educate and increase awareness of this condition so that we prevent progressive liver disease. So this slide shows the natural progression of liver disease in people with MASLD. So liver disease from MASLD, as I mentioned, can silently progress. That fat will build up, and patients even those that do not drink alcohol, they just have fatty liver, these patients can progress to cirrhosis. Patients don't believe it. First off, they feel fine. They feel like if they don't drink, there can't be anything wrong with their liver. They feel like if their liver enzymes are okay, that there can't be anything wrong with the liver. So those are some common misconceptions. But when we're talking about MASLD and MASH, just to break that up. So MASLD is the broader category of fat buildup in the liver, whereas MASH is a subtype of MASLD. So that's where the liver actually becomes inflamed and there's some damage there. So it's a more severe form of MASLD. I think of that as my MASLD patients are F0 to 1 fibrosis. MASH is F2 and above. So we have starting point, we have 60 to 80 million Americans with MASLD. So people with fatty liver due to metabolic issues. Now, a portion of these MASLD patients also have MASH. So these are the ones that develop that inflammation. And these are 15 to 20 million people. Now, of the MASH patients, 20 to 30% over 3 years can develop some form of fibrosis or scarring in the liver, anywhere from stages 1 to 3. So that's 13 to 16 million people. Now, those that have F3 fibrosis, 20% can develop cirrhosis in 1 to 2 or in over 2 years. And that's 1 to 2 million people now with cirrhosis. So fibrosis progression rate in MASH is about 1 stage every 7 years, and 20% of patients are fast progressors to cirrhosis within 10 years. Now we know cirrhosis can lead to liver failure, and it can, then it requires liver transplant, and if that doesn't happen, the patient could die. So 30 to 40% of patients with cirrhosis actually die from liver disease as the primary cause. And hepatocellular carcinoma at any stage, anywhere from MASH to fibrosis to cirrhosis, any of these patients can develop liver cancer. So when we're looking at initiation and progression of MASLD, so this slide basically shows the worsening that can happen in the liver from normal to liver cancer. And there are a combination of things that happen. So genetic risk, metabolic health issues, the gut microbiome changes, all of these potentially can lead all the way to liver cancer. So we know once that you develop fibrosis, it can progress or it can regress. The liver is very good at regenerating itself if you take care of it. But once you get to cirrhosis and a certain progression of fibrosis, the liver is pretty scarred and it's not going to regress. It becomes irreversible. It's a little bit too far gone. So this slide explains the changes over time. You've got normal, healthy liver on the left, and then you have MASLD. Remember, that's fat starts building up, and there's some metabolic issues. And then F1 to F3, this is fibrosis or scarring of the liver. Cirrhosis is severe scarring of the liver. And then HCC, of course, is liver cancer. So over time, this can progress, and there are some key influences. So there are, on the left-hand side in the red, genetics can play a role. Certain genes can increase the risk of MASLD, like PNPLA3 and the others listed there. And then if you look at in the blue after MASLD, there is a protective gene, and these patients that have this protective gene, this HSD17B13 with a specific allele, this may help to slow that progression to fibrosis or scarring. There are metabolic factors that also play a role, and that is on the pink arrow. So those patients with obesity, diabetes, metabolic syndrome, and alcohol use. This can increase the risk and progression of fibrosis. And then down at the bottom on the yellow arrow, so gut microbiome bile acid alteration. So there is less microbial diversity, more harmful bacteria, a shift towards gram-negative microbes, and these changes in this bile acid gut microbiome system, all of this can worsen liver health. So the AASLD guidance 2023, the key points are that MASH plus F2 to 4 fibrosis equal a higher risk for liver-related events and mortality. So these are the at-risk MASH patients. The rates of fibrosis progression and hepatic decompensation depends on multiple things. As I just showed you, it could depend on genetic, individual, environmental, and comorbid diseases. Cardiovascular disease and non-hepatic malignancies are the most common cause of mortality in a patient with MASLD that do not have advanced fibrosis, but death from liver disease predominate in patients with advanced fibrosis. So now let's look at a case. This is JP. He's a 55-year-old white male. He has a BMI of 35. And he comes in with elevated liver enzymes. He's had some right upper quadrant discomfort. So of course he's gonna get an ultrasound, right? Rule out cholelithiasis. 20-pound weight gain over 5 years. Mostly normal liver chemistries, but some intermittent elevations, mainly ALT and AST, nothing crazy, normal alk phos and total bilirubin. So he is obese, he's 230 pounds, BMI 35, he is pre-diabetic, hemoglobin A1C is 6.3, he does have hypertension. In fact, that's the only medication he's on is lisinopril, an antihypertensive. No known family history of liver disease, and he drinks alcohol rarely. He works in IT, and he does have a waist of 110 centimeters. So looking at patients like JP, whenever we see anybody with elevated liver enzymes, we want to take a look at the full picture. See what medications patients are on. We know that some medications are known to be associated with development of steatosis or exacerbation of fatty liver, and some of these are listed here, such as methotrexate, tamoxifen. And then always look at additional etiologies. Get that serology for abnormal LFTs. So I'll talk about what that is in a minute. Rule out, hepatitis, celiac disease, and some of these other etiologies listed here. So in addition to liver enzymes, some other tests that we get, we have a whole abnormal liver serology panel that we usually get, and this includes viral hepatitis, A, B, and C. We check iron studies, important to make sure patient doesn't have increased ferritin, or then you want to rule out hemochromatosis, AMA, ANA, anti-smooth muscle antibody, celiac disease, so get a celiac panel, alpha-1 antitrypsin, your blood counts, your electrolytes, your liver enzymes, and your clotting factors. Rule out HIV, thyroid disease. I would say most of the time lipid panel and hemoglobin A1C, patients already have come in with that. That's ordered by primary care, but if it's not, it's important to look at that as well. Now, PEth testing is not something that I do in my regular serology. I feel like that is done more in the hospital setting where patients are coming in with high alcohol use. But I will say, so PEth testing is for patients that you suspect, maybe greater alcohol use than they're saying. So this is a serum biomarker that can detect alcohol use actually within the last 28 days with excellent sensitivity and specificity. So it detects like 20 to 80 nanograms, and the person very likely consumed 2.5 or greater standard drinks for several days prior to the test or binged rather heavily. So this would be helpful. So if you have that patient sitting in your office and you ask them about alcohol and they swear up and down that they do not drink any alcohol, yet the exam room reeks of alcohol, that's where you would want to get that PEth testing. And abdominal imaging. So when we get an ultrasound, ultrasound-based imaging only detects moderate to severe hepatic steatosis. So it's not very sensitive for detecting mild steatosis. So sometimes you will see mild steatosis on an ultrasound, so that could be a little bit misleading, or maybe it's underestimated and it could be actually worse. So anytime you see any steatosis, make sure you follow up with some non-invasive tests. Get a Fib4, FibroScan if you have access, or do that referral if patients do have other metabolic conditions or persistently elevated liver enzymes. So you can consider that maybe an early warning if it just shows mild steatosis. So remember that detection on ultrasound really depends on operator skill. It depends on the how good the machine is, the quality, and many patient factors. Are they morbidly obese? Do you have overlying bowel gases, things like that? So back to our patient JP. So his ultrasound shows increase in hepatic echogenicity with typical regions of focal sparing. Contour appears smooth. He does not have splenomegaly. The impression here is hepatic steatosis with no evidence of portal hypertension. So which patients still need liver biopsy? So we have all these non-invasive tests, but some patients we still need a more complete picture or a clearer diagnosis. So sometimes we get those conflicting results, like I mentioned previously. So in stage F2 versus F3 fibrosis, if the non-invasive markers are indeterminate or discordant, you might still want a liver biopsy. And also consider in the older age, greater than 65 patients, or you want to rule out concomitant liver disease like autoimmune, iron overload, things like that. The pictures on the left, you see isolated steatosis. So that is basically just fat in the liver without inflammation. Steatohepatitis or MASH at the bottom includes inflammation and some damage, not just fat. So JP definitely checks the box for metabolic associated steatotic liver disease or MASLD. So remember, he has an ultrasound that shows steatosis, so that checks the first box. He actually has 3 out of the 5 positive metabolic criteria. Remember, his BMI is 35, his waist circumference is 110, his hemoglobin A1C was 6.3, and he's on lisinopril, which is an antihypertensive. So he checks the first 3 boxes there right off the bat. So what's the next step for JP? So these are some questions to think about. We need to think about, does he have underlying steatohepatitis or MASH? Is he one of these at-risk patients we really need to keep an eye on? Does he have any fibrosis? And does he have advanced fibrosis, F3 to 4? So that concludes today's presentation. Again, thank you so much to GAP and to Madrigal for making this possible and, expanding everybody's education on fatty liver. Thank you.